some new knowledge and hopefully believing that quasi-experimental research design is not that horrible. It could be enjoyable and nice. So first, I will be covering some of the main objectives for this talk, and then we will talk about practical insights for the researchers, and maybe we could have a question and answer section at the end of this seminar, but also please feel free to interrupt at any time if you have any questions. So the main objectives for this seminar are first, to provide an introduction to the applied social research in the health services context, and then to explore the theory of development and its role in research, then to discuss the causal inference in the complex healthcare settings, and finally to review some quasi-experimental research designs and appropriate analytical methods. So what is applied social research in health services research context? I definitely do not need to preach about research to anybody in this room or on Zoom, but I will just give some background or context so that we understand better where the quasi-experimental research designs fall in this research context. So research is a macro endeavor in order to expand the existing body of knowledge or the literature. And there's this research practice continuum along which there is translation that occurs so that we can understand what evidence we are generating and how we can inform policy and practice. There are different types of research. The descriptive research, where researchers attempt to answer the following nature of questions. What is going on? And then there's the explanatory research, where researchers try to answer the question, why is it going on? And this is where causal explanation comes into play. And this is where we will be focusing today. And there are two different types of causal explanations. The deterministic causal explanation, where one factor X determines or predicts another factor Y. And there's another probabilistic causal explanation, where a factor X determines the probability of a certain outcome. And quasi-experimental research designs fall under this type of causal inference. So research validity. We do use some principles to judge the quality of the research or the validity of the research. But when we say validity or quality, what are we exactly talking about? What type of validity? So it's basically the extent to which the conclusions that are drawn from observations of the world are warranted. And there are four different types of validity. The internal validity, which is the extent to which we can make sure that we are drawing causal inferences between two different factors. And then we have external validity, which are the degree to which we can generalize the results from a certain sample or population or place or time to a greater setting, larger setting. And then we have the construct validity, which is basically to what extent can we draw conclusions about relationships between two constructs from relationships between two measures. And finally, we have the statistical or the conclusion validity, which is to what degree did we appropriately account for chance to have influenced the results that we are seeing. And again, causal inference methods or quasi-experimental research designs aim to increase or maximize internal validity or the causal relationship. Theory development. So there are four different steps in theory development. And theory development is very important to set the stage for any impact evaluation study. First, how do we construct a theory of change? We need to understand that a theory of change is a description of how a certain intervention is supposed to deliver the desired results. So it's basically focusing on the causal logic that links a certain exposure to a certain outcome. And then it depicts the sequence of the events that lead to the outcomes through different mechanisms or causal pathways. Basically, a theory of change explores the conditions and the assumptions that are needed for change to take place. And it is especially important in programs that seek to influence behavior. Human behavior is very complex. And if we do not understand how a certain policy changes a person's behavior, it's going to be very hard to really establish causal links between a policy and a person's outcome. And finally, literature review is very essential when we are constructing a theory of change, because we need to understand what evidence is out there that is linking the different steps between an exposure and an outcome. So to give you an example, from adult health insurance expansion to infant outcomes, how are these two even linked together? When we talk about expanding health insurance for adults, why do we even think that we might see any impact on infant outcomes or children's outcomes? So in this paper, my co-author and I tried to understand the causal effects of Medicaid expansions under the Affordable Care Act on infant mortality. And this is actually a paper that draws on a very clear and explicit theory of change. There is evidence in the literature that states that expanding health insurance to adults that are low income and vulnerable and with the greatest healthcare needs, we will see evidence of increased access to care and increased utilization of primary care and preventive care, as well as mental health care. And this is actually leads to better improved health outcomes, particularly among women of childbearing age. And so expanding Medicaid expansions would improve women's preconception health. So women would enter pregnancy in a better state, overall health state, and mental health state. And this is related to better birth outcomes, which in turn leads to decreased infant mortality. And these different causal pathways and mechanisms would actually link an insurance that was designed for adults and child outcomes. The next step in theory development is developing a results chain, which sets out a logical outline of how a sequence of different inputs, activities or processes, and outputs for which a treatment is directly responsible interacts with the behavior to establish the different pathways through which impacts are achieved. So first, we would have inputs, activities, and outputs, which are known as the implementation or the supply side of any policy or program or intervention. And then we would have different outcomes, whether these are short-term, intermediate, or long-term. And these are the results or the demand side of any program or exposure. So this results chain would inform the rest of the research design. Particularly, the researchers, after understanding this chain, they would be able to refine their goals for the research question. They would be able to identify potential threats to the validity of their conclusions, and they would be able to select the appropriate methods and justify their research. And to make it a bit more concrete, I'm going to give you an example about health interventions and the pediatric vaccination rates in low-income communities in the US. So this is a program that was designed by the government, and it's a hypothetical example. It's not anything real. So this is a program that was hypothetically designed by the government to increase or optimize vaccine uptake among the pediatric population. The inputs for this program or health intervention consist of training healthcare professionals and community health workers, distributing educational materials on vaccination benefits, and establishing partnerships with local schools and community organizations. Some of the activities to make this intervention happen would involve outreach and education campaigns, free vaccination clinics at accessible locations, trained healthcare professionals and community volunteers, and implementation of reminders or recall systems to notify the parents. And some of the outputs would include the number of educational sessions that have been completed, the number of trained providers and volunteers, and the number of notifications that were sent. And if we want to look at some of the outcomes of this health intervention, the short-term or immediate outcomes would consist of increased awareness about the vaccination important among the parents, higher use of vaccination clinics, and enhanced community provider trust. More intermediate outcomes would involve higher on-time vaccination rates, reduced incidence of vaccine-preventable diseases, and stronger collaborations across the different sectors in the community. And longer-term outcomes would be improved health and well-being, lower costs, and increased equity. So understanding these different steps along the results chain would really help strengthen the causal evidence between this intervention, which is community health intervention for the low-income parents, and then long-term outcomes.
Can I ask you a question?
Yeah.
You know, one thing that I think we all know, since we work across so many different disciplines, is that things are called different things in different disciplines. And so, for example, this looks like what the CDC calls an evaluation and management plan and output. are there differences? At least I think so, based on what those are. Could you see differences in that, or are there different ways that we've referred to this across disciplines that you can think of?
I think probably, like, I'm not sure what other disciplines would refer to that, but in general, this is impact evaluation.
Okay.
And the main objective out of it is to establish causal impact rather than just association. And in order to be very confident and in saying that this particular health intervention or program or policy resulted in these outcomes, we have to go through the different steps. But I'm pretty sure there must be like different language or, yeah. Did this answer?
Yeah, that's
great. Okay, the third step would be specifying the evaluation question or questions, or in other terms, the research questions. Now that we know what are the different steps, what are the different outcomes, it would be much easier as researchers to just ask a question that we would like to attempt to answer. The questions must be clear, they must be tailored to the policy interest at hand, and they must be structured as a testable hypothesis. So the basic impact evaluation question in general would look something like this. What is the impact or the causal effect of a certain treatment on an outcome or different outcomes of interest? And the focus here is on impact, which measures the changes that are directly attributable to the treatment. And the treatment could be any new drug, it could be a surgical procedure, it could be health insurance coverage or eligibility standards, it could be any governmental rate setting, it could be anything. It doesn't have to be a medical treatment. It's an exposure to something, to a program. And then the outcomes could be anything as well. They could be access to health services and utilization of health services. These could be healthcare expenditures, health outcomes, or patient satisfaction. So to give you an example, a more concrete example of how to write research questions, depending on the different outcomes, if we want to look at the short-term outcomes, the research question from the example, from the previous example, the research question could be something like, does community outreach and education programs increase the patient's knowledge, the parents' knowledge and awareness about the importance of vaccinations? And then we would definitely have to set a priori the different hypotheses and what would the researchers anticipate to see. And again, for the intermediate outcomes, the research question could be something like, does providing free or low-cost vaccination clinics lead to higher rates of on-time vaccinations among the children? And finally, for the longer-term outcomes, the question could be something like, does increasing the vaccination rates among the children in low-income communities result in improved overall health? And we would have hypotheses for all the questions. And finally, the final step in theory development is selecting the outcomes and the performance indicators. These should be clearly articulated, and the results chain is really useful for the researchers to pick their indicators very carefully at each step along the way. Good indicators are SMART, specific, measurable, achievable, relevant, and time-bound. And some examples, let's say from the previous example, could be for the short-term outcomes, the parents' knowledge and awareness about vaccination. How is this specific? The research could measure parents' knowledge in a very specific way by looking at the increase in the percentage of parents that correctly answer at least 80% of questions on a vaccination knowledge quiz. So that could be like one way to determine, to quantify in a very specific way their outcome of interest. And how is it measurable? Researchers have to collect data pre and post intervention through surveys, for example. It's achievable when researchers a priori set a goal, like for example, they would aim for a 20% increase in parents' knowledge, and that goal should also be set a priori in order for it not to be influenced by the results of the project. And it's relevant, definitely relevant for the program or the treatment of interest, because increased awareness is key for improving the vaccination decisions. And this is time-bound when researchers say they will look at this outcome within 6 months of starting their outreach campaigns. And the same thing, they can pick their intermediate and long-term indicators similarly. So now we come to the fun part, the causal inference in the complex health settings. What is the counterfactual? This is a very, very important concept in health settings. And you can think of the impact of a treatment usually as the difference in outcomes Y for one same unit with and without participation in a certain exposure, treatment, program, or intervention. However, there is one small problem. We cannot measure the same units with and without a certain treatment at the same time. It just doesn't happen. And this is the counterfactual problem. So how are we going to look at the difference in outcomes among a certain population with and without the treatment, so we can get at the cleanest causal impact of a certain treatment? The key to this is to have a valid comparison group. Since we cannot observe the same people at the same time, we have to find an alternative group that is similar enough to our treatment group so that we can compare outcomes. A valid comparison group would have the same characteristics on average as the treatment group in the absence of the program. It should remain unaffected by the treatment, and it should react to the program in the same way as the treatment group would have if given the program. There are two counterfeit estimates of the counterfactual. So we can estimate the counterfactual in different ways, but these are not perfect. The first one is comparing outcomes before and after a program. So as you can see here, we have a certain treatment over time. We can compare the outcomes Y in the pre-period to the outcomes Y in the post-period. However, we would be faced by some threats. The first one is the history threat. So if we just do that and we look at the difference in the before and after, we might run into this issue where some other things happened at the same time as the treatment that we are not aware of. And these things could be affecting the outcomes. Another threat is maturation threat. So if we only look at people before and after a certain treatment, they could have matured in some way. And so they have changed. Our units that we are observing are different right now. So it's not a very clean estimate of the impact. And then we have the testing threat, which means that when we test the same people before a certain treatment, they now get some different insights into the treatment of interest. And so if we test them after the treatment, their answers or their outcomes would be influenced. So this is not very optimal. Another counterfeit estimate of the counterfactual is basically just focusing on the post period after the treatment has been given and comparing the treated and the untreated groups. But there is a big threat here, which is the selection bias. So if we give people the option to self-select into the treatment, the people that are going to choose enrolling in a certain program or taking up some health insurance are very different from the people that choose not to. And for the people that attended my WIP last week, we had some conversations about who are the people that are taking up CSHCS? Are they very different from the people that are eligible but are not taking CSHCS? What is leading them to this difference?
Wow.
Just say that.
All on that. It was kind of a before and after.
You're good, you're good. Keep it just like that.
Oh.
The camera was so impressed.
Right.
So selection bias is very important, but wouldn't it be great if we can just get rid of this bias? Of course, and we can actually get rid of this bias. Randomized controlled trials, or RCTs, which are very popular in medical settings, are the one and only gold standard for estimating the causal effect of a treatment. And the key here is the randomization. So the population of interest would be randomized into a treatment or a control group. So probabilistically speaking, on average, the two groups are equivalent on both observed and unobserved characteristics. So we wouldn't really be worried about people self-selecting because they are more risk averse or they place a higher premium on their health. It's just a random assignment. But there is growing interest in using quasi-experimental designs for different reasons. RCTs may not always be ethical or feasible. They are very expensive and require a lot of resources. And sometimes, or a lot of the times, the researchers do not have the control over assigning people randomly into treatment and control groups. And finally, there might be some spillover effects in RCTs, where people contaminate each other if they are in contact. So the control group would be contaminated by the people from the treatment. And again, the estimated impact would not be so clean. And that's where we use quasi-experimental designs and the appropriate analytic methods. Brace yourselves, econometrics is coming, but I promise it's not so scary. First method is the difference in differences. And just to give you a very brief overview of this method, it's a quasi-experimental technique that is used to understand the effect of a sharp change in government policy or economic environment. So it may be used in conjunction with natural experiments that happen, such as a policy, a state-level policy change, or economic policy, to identify the sources of variation in the treatment. And the key here is that this technique compares changes in outcomes over time between a population that actually received a treatment or the treatment group and a population that did not receive a treatment or the comparison group. So as you can see here, if you remember from the counterfeit counterfactuals, we have pre and post. The first difference we do here in this difference in differences is the difference between the outcomes of the treatment group in the pre-period before the treatment and the post. So that's the first difference. It controls for time invariant factors, since we are looking at the same group of people before and after. So if they have some unobserved characteristics like motivation or risk aversion, we are controlling for that because we are looking at the same people. However, we are still left with time varying factors, like the history threat, if you remember. So if something else has been going on at the same time, we did not account for that. It could have contaminated our impact. That's when the second difference comes, where we compare the difference in the outcomes in the pre-period and the post-period among the control group or the untreated group. And this control group has been exposed to the same set of environmental factors. So this history threat is basically accounted for now because we are looking at the impact on this group that has been experiencing the same thing. And then what we do in the definitive is basically cleaning the first difference from the second difference, and we would be getting at a very clean causal impact. There is, however, one very key assumption that we have to keep in mind for the difference in differences to be a valid identification strategy of the causal effect, which is the parallel trends assumption. In the parallel trends assumption, we assume that in the absence of the treatment, whatever that treatment is, whether it's a policy or a medication, anything, in the absence of the treatment, the outcomes of both treatment and control group would have kept moving in tandem. So that, for example, in this graph, you can see on the x-axis, we have the time. Year 0 is when the treatment was implemented. And on the y-axis, we have the outcome of interest, no matter what that outcome is. The black pattern and dots is that of the treatment, and the gray one is that of the comparison group. So as you can see in the pre-period, before the implementation of that treatment or the policy change, whatever that treatment is, both groups were moving in tandem, they were parallel. And we would assume if this treatment didn't occur in year 0, they would have kept moving in tandem, in parallel. And so the only change here is basically the treatment. And whatever difference we see after the policy or the treatment is basically our impact, our causal impact. I'm not going to go into this equation, but I just want to say that in the DD, your main coefficient of interest, if you are planning to implement this technique, would be beta 3, which is the coefficient of an interaction between an indicator for being in the treatment group times an indicator for being after the implementation versus pre-implementation of a treatment. One of the limitations of the definitive technique is that even if the parallel trends assumption is valid, and we do see parallel trends before the implementation of any treatment, we can still have some bias if something happens after the implementation that affects differentially both groups. And we do not account for that if we don't know about it or we just couldn't account for it. So just keep that in mind. And I think I'm gonna skip the example just for the sake of time. Another quasi-experimental technique is the instrumental variable. It's a very popular and common methods in quasi-experimental health services research. And this is an alternative method that solves endogeneity problems when the variables influencing the outcome are unobserved. It helps evaluate the treatments with imperfect compliance, voluntary enrollment, or universal treatment. So whenever people can choose if like self-select into a certain program or not, IV is a very interesting technique to use. It relies on some external source of variation to determine the treatment status and something outside the individual's control influencing their likelihood of taking up a treatment, but is otherwise not associated with their characteristics is basically the main foundation of IV. So again, it's very important to look at external factors that are close to randomization rather than internal factors that are affected by individuals' characteristics, unobserved characteristics. So in this figure, X is our treatment of interest, whatever that is. Y is our outcome of interest, and A is a set of confounders. Confounders affect both the treatment and the outcome, and we have to deal with them. So we can think of Z as an instrumental variable or IV, and this instrument basically affects the treatment, the probability of taking up a certain treatment. And you can think of the instrumental variable as an encouragement. It could be like a brochure that was distributed randomly to different groups of people to encourage them to either take up CSHCS or take up Medicaid if they are eligible, or just go for a well-child visit, whatever the treatment of interest is. So let's make it a bit more concrete. Let's think of a scenario where our main exposure is child well visit. We are interested in understanding the causal effects of going to a child well visit on time, on immunization rates, or on HbA1c levels among diabetic kids. There are some confounders that affect both the treatment and the outcome. These could be age, parental education, health beliefs and attitudes, and so many others. But these are really things we might be able to control for in the models because we usually have information on these factors in our data sets. But there's another concern. So there are some unmeasured confounders, like for example, risk aversion, placing high premium on good health, and different other factors that might actually lead the parents to self-select into taking their kids to well-child visit versus not. And this is our self-selection thread that we need to deal with. So one way to deal with this self-selection thread is, again, random assignment, but it's very unethical to randomly assign people to go to a child visit versus asking them not to go randomly. So what we can do here is basically use an IV method to randomize people. And this could be through an encouragement to go to the well visit or receive usual care. And when we do that, we are kind of dealing with this unmeasured confounding like risk aversion. It's now part of the things we are dealing with. And as you can see, we have like a big relationship between our instrument of interest and our treatment of interest. And then the relationship between the confounders and the treatment is now smaller. So the more our instrument can impact the treatment, the less the treatment is now affected by our confounders, and the closer our treatment is to being randomly assigned. So we have kind of dealt with this self-selection bias. We have two major assumptions or conditions for the instrument to be a valid instrument. The first one is relevance. So relevance means that any particular instrument has to have a high probability of predicting the treatment. The other assumption states that our instrument should not be related to our outcome of interest except through its effect on the treatment. So Z can only affect X, and it is through its effect on X that we will see some changes in the outcomes. There is no direct relationship between Z and Y, and there is no direct relationship between Z and our confounders. And this is called the exclusion assumption or exclusion condition. And I know, by the way, Sarah, I think probably you refer to A as colliders, right? Collider?
No,
Or,
no. but
okay.
Yeah, I know what you're getting at, yeah.
Okay. As for the analytic technique, again, I will not go into the details of the econometrics behind it, but you can just know here the main takeaway could be that the analytic approach consists of something called 2SLS, which is the two-stage least squares. In the first stage, we would be regressing our treatment of interest on our instrument over here and all the other confounders and our variables that we will be controlling for in the model. So we would obtain the fitted values of X or the predicted values of our treatment. So we are basically cleaning our treatment from confounders. And then we take these fitted values and we go to stage 2, where we regress our outcome of interest on the fitted values of X and everything else. And the coefficient on X hat, or the fitted predictor, alpha 1 is basically a very clean causal effect. So we would be able to get at a very clean causation out of this IV.
What is that? Yeah.
Oh my God.
It's like your voice going a little bit powerful.
Okay, so we have a couple of limitations for this quasi-experimental method that are important to keep in mind. The first one, we need to have a very strong instrument. And it's really hard to convince people if you go to an econ department where people are presenting a research study that involves instrumental variables, they're going to be attacked very aggressively in an attempt to try and understand why is this particular variable a very valid instrument. So that's one thing to keep in mind. It's not easy to find a really good instrument, but you can do it. And the second limitation is the estimated causal impact is one of the cleanest causal impacts that you can estimate, and you can use to convince policymakers of the impact of a certain policy or intervention. However, it's very limited. There is a restricted external validity. If you recall, external validity is generalizability of the outcomes. And the instrumental variable is basically helping us find a very clean impact among people that take up a certain treatment or exposure only because they were encouraged to take it up. So you cannot really infer or extrapolate this estimated impact to other people that would have taken up this treatment regardless of the encouragement. So it's very limited to this subgroup of the population. And here's like another example, just to make it a bit more concrete. So if we go back to the vaccination status, we want to look at hospitalization rates as our outcome of interest. We have a bunch of confounders, and then we have a brochure encouragement, which is our instrument of interest. In our first stage, we would be regressing our treatment, which is the vaccination status, on our instrument, which in this case is the received brochure. We find chi1 is equal to 0.3, which means being encouraged or being randomly assigned into encouragement to take up treatment is associated with a 0.3 percentage point increase in a person's likelihood of actually taking the treatment or going or getting vaccinated on time. And then in the second stage, what we do is we regress our outcome of interest, which in this case is the hospitalization rate. We regress that on the fitted values of vaccination or the predicted values that we got from the first stage. And we would get at beta 1, which is our estimated causal impact. And this means that if you want to interpret it, it means that vaccination or the predicted values of vaccination are associated with a 0.2 unit reduction in hospitalization rates. And finally, the third quasi-experimental design that I will be discussing today is the regression discontinuity design, also known as RDD. And this is a design to estimate the causal effect when the assignment of a certain treatment X is based on a cutoff value, score, or index. One example could be the poverty scores, like income and asset tests for Medicaid eligibility. And here in the US, it's the cutoff point is 138% of the federal poverty level in the states that have expanded their Medicaids under the Affordable Care Act. So anything that is below 138% of the federal poverty level would make a person eligible for this program or intervention. And anything above this cutoff would make a person ineligible for this treatment. So it's very random. It's not something that people could self-select into. Another example could be age for Medicare. So again, 65 years is the cutoff. People just below 65 years are not eligible for Medicare, and people right above 65 are eligible. So they are considered to be randomly assigned. It's something outside of their control. They cannot self-select into this program or insurance. And another example could be, for example, test scores for scholarships. Let's say 14, I'm not sure if that's true, but let's say 1400 score for SAT is like a cutoff for a scholarship. So anything below 1400 does not qualify for a scholarship, and anything above that would qualify. And again, we can safely assume that people are randomly assigned into whatever intervention. But we have some key conditions to keep in mind as we think about employing this RDD in our study. The first one is our variable of interest that has a cutoff should be a continuous measure on which the population of interest can be ranked. So as we just saw, it could be like acid tests, or it could be income. So it could be a score, it could be age. It has to be continuous in order for us to have a clear cutoff point that we can rank people on. And then we should have a clearly defined cutoff score, which has to be external. It's not something that the researchers decide. It's something natural that happens through a policy or a certain program. And as you can see in this graph, on the x-axis, we have the running variable, or the variable of interest, on which we can rank people. And we have C, which is the cutoff that would determine whether a person is eligible for a certain program or not. On the y-axis, we have the treatment, the probability into getting assigned into a treatment, which is either 0 or 1. If you are below a certain cutoff, you would have a 0 probability of getting treated because you do not qualify. But if you are right above the cutoff, you would have 100% probability of getting assigned into a treatment. And this is again very random because people supposedly cannot decide. They are just assigned. Some other conditions, the cutoff should be unique to the treatment of interest. So if we have 138% of the federal poverty level as the cutoff for Medicaid eligibility, this 138% shouldn't be a cutoff for any other program, because otherwise we would not be able to really disentangle the effects of Medicaid. It could be due to the other program. And the units score cannot be manipulated. So we have to make sure that a person cannot manipulate their income to decrease their income to less than 138% of the federal poverty level and then qualify for Medicaid. It has to be, they shouldn't be able to do that. However, sometimes it happens. Sometimes people can manipulate their conditions so that they either qualify or not for a program. And we would be able to tell through some tests that we do. And as you can see in these graphs, if there is no manipulation, then you should have like a smooth curve or distribution of the people right below and right above the cutoff. But if there is manipulation, you will not have a smooth distribution of the population. For the analytic technique, again, I will not go into all the details. I just have the equation here for the reference if you would like to keep it for your own reference. But it's important to understand that what RDD basically does is it estimates the impact around the eligibility cutoff as the difference in the average outcomes for the units that are on the treated side, whether that's above or below the cutoff, and the average outcome for the units on the untreated side or comparison side. And since the people that are right above or right below the eligibility cutoff are so similar, the only thing that differs is literally just their assignment into treatment or control. So you can just compare the means, the difference in the means or in the average outcomes, but you can take it a step further and you can run regressions and control for additional stuff, which is very feasible. And again, you would be getting at something called the late, which is the local average treatment effect. Similarly to the instrumental variable, it's one of the cleanest causal impacts you could ever estimate, but one of the drawbacks is the limited external validity. Since it's very concentrated among the people that are very close to the cutoff, So we're not sure how far away you can go and generalize the results. So this is basically what I just covered about late. And the other limitation of the RDD is the possibility of having a fuzzy RDD, where the probability of the treatment is discontinuous at the cutoff, but not to the degree of a definitive 0 to 1 jump. So again, some people might manipulate their circumstances so they can be eligible to a certain program or policy versus not. But there are some econometric techniques that we can use and implement in order to deal with that. So first to detect it and then to deal with it. To make it a bit more concrete, this is another hypothetical example where schools with an average student BMI above greater than 25 are mandated to implement a health intervention program that is aimed at improving children's health and academic performance. So the research question in this case is, does receiving an in-school health intervention program improve the academic performance among the children? As you can see in this table, these are all fake numbers. For the different schools, we have the different BMIs, average BMIs of the students. We have their performance on the tests, which is our outcome of interest. And we have in the last column their assignment into treatment or control. And again, this is beyond the ability of the school to self-select into this health intervention. It's purely based on the average BMI of the students at that particular school. So this is the equation that we would be fitting. This is the model that we would fit in order to estimate the causal impact. And in this case, the causal impact would be captured by tau coefficient. In this case, if we just fit this model, we would get that tau is equal to 12.47, and it's statistically significant at 1% error rate, type 1 error rate. And so this means that the health intervention in question for the schools with a BMI greater than 25 causally improves academic performance by 12.5 points relative to the schools that are just below the threshold. So now that we have an idea about different types of quasi-experimental designs, some of the main takeaways to keep in mind as people work on their projects, it's important to understand the theory and the causality in your health services research. Particularly if you want to get at the causal impact, you have to establish this theory of change, the results chain, and the different mechanisms or causal pathways through which your intervention is anticipated to be linked to your outcomes. And it's also important to understand those rigorous analytic methods and the different equations on how to link the different things together, the treatments, the outcomes, the confounders, and how to control for them in order to get at the cleanest possible estimate. So quasi-experimental designs offer practical solutions when RCTs are not feasible, but definitely whenever RCTs are an option, RCTs are the gold standard, and it would be great to actually have a randomized controlled trial. But keep in mind that it's not always the case, it's not very common, and when you are faced with the option of quasi-experimental designs, how can you choose the right quasi-experimental design for your research? And most of the times you can choose more than one, but you just want to use the best one. So first, keep in mind the intervention's operational rules. And by that, I mean the eligibility. So who is eligible for your program or for the treatment or for the policy or for the insurance? And based on that, you would understand what would be the best comparison group so that you can construct the most valid counterfactual. So that's important to keep in mind as you're thinking through which method is the best. The second thing to keep in mind is the underlying assumptions and the data requirements. So as we saw for these three methods, the diff and diff, IV, and RDD, each one of these methods has its own assumptions and its own data requirements. So just keep in mind, if you have an option to choose between two, the one that needs the less data and the one that has the weakest assumptions is probably the way to go. And finally, the choice of unit of intervention. You always want to go to the smallest unit possible. So if you could analyze at the individual level, that would be optimal. But sometimes you will not be able to do so depending on eligibility or implementation, if it's at the state level or at the hospital level or at the school level or district level. But also keep in mind that on the other side of this, sometimes going to the individual level is not necessarily very optimal, particularly if we have contamination issues. So if people in the treatment group can interact with the people in the control group and affect their choice and their outcomes, then in this case, scaling up or going one level up would be better. So just keep in mind these 3 points as you are deciding which quasi-experimental design you want to use. And finally, before ending, I just wanted to share this resource. It's a textbook by the World Bank, Impact Evaluation in Practice. It's great. It covers these 3 quasi-experimental methods and a lot more. It's not intended for econometricians. It's for people that do not have background in economics or econometrics. So it's really helpful. If you are interested, I have a PDF copy I can share with you. And I also added the link. I can share the slides after the seminar. You can also download it. It exists in different languages. So this is a very important reference to have. And it summarizes very nicely the different methods. And you can also, that's all I have. You can feel free to email me if you have any questions about these or other designs, or if you'd like to discuss anything about future projects you want to brainstorm, I would be more than happy to do that. And yeah, thank you.
Thanks for that. That's really helpful. I just want to acknowledge that this is an interdisciplinary kind of forum here. So one of those designs that was not included in your presentation, which I think might have been presented if you were a biostatistician or epidemiologist possibly, would be an interrupted time series design. So this is not something that the economists don't like this design, even though I actually read a paper, an NPR paper that actually said they called it a regression discontinuity in time, but it's basically what an interrupted time series is. My point just being that there are other quasi-experimental designs that come from other disciplines that certain disciplines don't like and some certain do. I just kind of want to acknowledge that we should throw ITS on the table. Not that like there are pros and cons of that design, don't get me wrong, like there are with any design. I just want to point out that some would quibble with your definition of quasi-experimental.
Thanks. Yeah, no, I agree. There are definitely much more. I just opted to present the 3 most common and cleanest methods. So yeah.
Those are fighting words. I don't have a bone I don't have a dog in this fight. I just want to say that there are some people who would argue that ITS is actually the strongest possible quasi-experimental inference. I mean, when you think of it on if you think of it like an RD, just using different methods, and oftentimes RD is thought to be as close as you can get to causal, like an RCT, in the absence of randomization, right? Some people, I'm not making a statement. We can have this argument. I'm just acknowledging that there are alternative viewpoints depending on your discipline.
That was excellent. Thank you. Really great summary. I was wondering, in the era of social media, what's known about contamination? Because everything is shared online. If you have a non-blinded quasi-experimental design, I think at this point in time, it's reasonable to assume that one group does know about the other group, or has a likelihood of finding out. Do we know anything about that?
That's a great point, actually. And I do believe that in these days, like nowadays, with all the social media and everybody being connected with everyone else, across the world, contamination is definitely a problem. But luckily, we do have some econometric techniques that we can employ to just clean any contamination. It's not applicable to all the different scenarios, but we would be able to deal with that in some specific cases. But it's important to keep that in mind because this is a problem that wasn't there before social media. Yeah, for sure.
And I just want to say, I've been to a lot of talks. This was so wonderful and so clear and so methodical how you walked people through every step. And I just want to say hats off to you. This was just a really, really great job.
Thank you, I appreciate it.
On a very related note, we have a QR code to provide feedback about Joanne's talk. The link is online and you can scan, for those of you online, there's a link you can go to and all of us in person can scan the QR code. Thank you for that transition, Gary.
I give and I give and I give.
Great, thank you, Joanne.